The doctor told me that, look, you have hepatitis B, so you cannot go overseas. No one at all from my village had that opportunity to go overseas for study. And for sure, my parents would not be able to afford any of that. So having a scholarship to study overseas is actually a really big deal for someone from a village in the north of Vietnam. And I was lucky enough to secure a scholarship to study in Europe. And as a part of the paperwork, I have to go through a health check, and hepatitis B test is among the health check. So when I came to get the result, the doctor told me that, look, you have hepatitis B, so you cannot go overseas. And then I had to reject the scholarship just because he told me so. I don't know why, by that time I didn't challenge him or explore more, whether what he said was correct. But look, as a first year university student and you had no experience in life, and then you tend to trust everyone that deemed to be more superior than you, like the doctor in the hospital.
In the time it takes to watch this 30-second video, someone will lose their life to hepatitis. It could be your parent, your partner, your child. It could be you. But it doesn't have to be this way. There is a cure for hepatitis C, a vaccine and effective treatment for hepatitis B. We have the power to eliminate hepatitis and save 1.1 million lives each year. It's time to act. Hepatitis can't wait.
Hoy es un día muy esperado para todos los integrantes de la Asociación Buena Vida, porque celebramos la cura de varios pacientes de hepatitis C. Nosotros en nuestro grupo decimos que vivir con el virus de hepatitis C es sentir que uno tiene una bomba de tiempo dentro de uno y que no sabe cuándo va a explotar. La cura significa desactivar esa bomba. Por eso estamos todos juntos hoy para festejarlo, entregar las remeras con la inscripción de hepatitis C curado, y ese es el momento cúlmine de nuestra labor como voluntarios de la Asociación Buena Vida.
Soy Raúl y estoy curado.
Soy Majo, estoy curada.
Soy González Julio y estoy curado.
Hola, soy Susana y estoy curada.
Soy José Luis y estoy curado.
Soy Graciela y estoy curada.
Soy Adrián y estoy curado.
Soy Andrés y estoy curado.
Hola, soy Miguel y estoy curado.
Hola, soy Gabriel y estoy curado.
Soy Carlos y estoy curado.
Soy Nelly y estoy curada.
Soy Claudio, estoy curado.
Soy Rubén y estoy curado.
So should we just go around and say hi?
Sure.
Tell us a bit about you. Where are you?
So my name is Rosemary Delab. I'm the community-based research manager at Coalition Plus. I'm based in Paris, but I am an American. So
fantastic.
Hello to everybody.
Yeah, lovely to meet you. Daniel, where are you?
Hi everyone, my name's Dan O'Keefe. I'm based in Melbourne, Australia, and Senior Research Officer for a medical research institute called the Burnet Institute here in Melbourne. Good morning to everyone, by the way.
Yeah, it's a morning for you, is it?
Well, it's just gone morning.
Okay, very, very early then. Sorry about it. But next to you, we've got Carrie. So I'm presuming Carrie's your colleague and she's on the same timeline?
Good morning, everyone. Yes, I'm Carrie Fowley from Hepatitis Australia. Yes, it's just ticked over 20 to 1 in the morning. From Hepatitis Australia. Yes, it's just ticked over 20 to 1 in the morning. From Hepatitis Australia. Yes, it's just...
We obviously, there's something going on with the planet today, and this isn't meant to be happening in the way it is. Hi, Catherine. Lovely to meet you. Where are you?
Hi, I am Catherine Freeland. Good morning, good afternoon, good evening to all of those joining. I'm from Philadelphia, Pennsylvania. I represent the Hepatitis B Foundation and Hep B United.
Fantastic. Lovely to meet you. I'm really glad to hear that Hep B's here in the meeting as well. Hi, Huma. Is it Humi? How do I pronounce your name?
Yeah, you have correctly, you have rightly pronounced Huma. It's Huma. Yeah. So hi. This is evening here in Pakistan. I'm a gastroenterologist by profession, and I'm the national focal point for viral hepatitis. And I'm basically a researcher, and I used to head the Medical Research Council for Pakistan. So I'll be going live whenever my time comes. So I'm ready. Hi. Thank you.
Maybe we should mix it round then. If somebody is
I thought that if we want to save time, then I could go live by the time you get the IT people and start the recordings.
Okay. Are we live on the session? Okay. It looks like we've just got a message up saying we're live. This is being shown to everybody. Let me just, okay, we've got slides. Okay, that's from Catherine. Let me just see, I'm just going to double check here. We didn't say hello to Suna. Suna, welcome. You're on mute.
Yes, hello everybody, I'm Suna, the doctor, HIV hepatitis advisor for Doctors Without Borders. Médecins Sans Frontières.
Ah, how exciting.
Yeah.
I'm going to see if we're live on the platform. I think we might be live on the platform. Let's have a look. Session live. Well, there's nothing coming up anyway. Okay, so as we have some people presenting live, shall we move it around and just go with the live presentations? Oh, we have missed somebody. I've got somebody sat in the room with me who is joining us too. Say hi.
Hi, hello everyone.
What's your name?
I'm Nalini Kanta from India, Manipur. At the moment, I'm in Geneva. Thank you so much. Nice meeting you all.
Nice to meet you. Okay, so let's show Huma. Do you want to share your screen and let's start?
Okay, so hi everybody, and I'm Huma Qureshi. As you heard, that I'm the national focal point for hepatitis, and I'll be sharing with you the micro-elimination of hepatitis C in the underserved communities of Islamabad. This work was funded by the John C. Martin Foundation, USA. And why did we choose to work in the slums of Islamabad? There were many reasons. The first was that this was an underserved, vulnerable population which belonged to a very low socioeconomic group. They had little knowledge about the viral disease and its transmission, and they had no access to the hepatitis C testing and treatment. So this is a snapshot of the slums of Islamabad, and you see there are 17 slums in Islamabad with a population of 50,000 people. And these are generally marginalized Christians who are low paid daily wages. So the project goals were that we would screen, test and treat patients for hepatitis C who were aged more than 12 years of age, increase the awareness about the hepatitis C infection, and give them the hepatitis B vaccination, and also undertake a verbal screening for tuberculosis and refer the potential cases to the TB clinic for further testing. So we used the community health workers approach, where we selected the community health workers from each slum, and these workers went door to door and tested the population for the rapid HCV using the rapid test, and they also filled in the demographic profile of the population. So once the screening was done using the rapid test, then those who were found positive on the rapid test, their blood was drawn for the RNA and for CBC, and the APRI score was calculated. And then those who were found positive for the virus, PCR was positive, then they were offered a treatment, which comprised of sofosbuvir and daclitesvir. And the duration of treatment was linked to the APRI score, where the dividing line was 1.5. So once the patients were put on treatment, then they were called 4 weekly for the follow-up to undertake the clinical evaluation and for the medical refill. And then once they completed the treatment, then their sustained virological response was checked at 12 weeks after stopping the therapy. And those who were found negative were labeled as cured. So you see here that we have these community workers going door to door, and one is entering the data on the questionnaire while the other is undertaking the rapid test. So these community health workers brought the questionnaires to the health facility where the data entry was done by the data entry personnel, and the personal identifiers were masked before the analysis was done. So the results are, you see that we screened in the slum population, we screened about 24,200 population, and 514 or about 3% were found to be HCV positive. And then they were put to HCV RNA, and 86% were found to be HCV RNA positive. And then they were put to treatment. So the treatment was started in 98% of the population. Treatment was completed by almost 90% of the population. And the cure rates were 98%. So the conclusions was that, you know, the same day testing and treatment, which was a one-stop shop, was a very great idea, and this promoted the retention of the patients. There was a very simple transition between screening, testing, and treatment, and all testing and treatment was provided free of cost. The limitations were that we could not collect the qualitative data of the refusals, people who refused to be tested. There were less efforts done on the prevention, and there was little follow-up on the tuberculosis questionnaires. The next step is that we thought that it would be, as this was a great success for us, so we think that this model could be replicated in all over Pakistan. And we could adapt the project and address COVID and other infectious diseases under the same umbrella. And thank you very much. And these are our partners whom I would like to thank for supporting us in this study. Thank you very much.
That's amazing, Huma, and just an incredible piece of work. Wow. Rather than do questions now, we're going to do some questions at the end. So if you've got any questions, please put them in the chat box. So you go for it, Catherine. That's amazing. If you don't mind, thank you.
Okay, so thank you. Sorry for the technical challenges, but that's the life that we live in this virtual space. I'm Catherine with the Hep B United Coalition, and founded by the Hepatitis B Foundation and co-chaired by APCHO. So the Hep B United, just a bit about us. We are a national coalition based in the United States that's dedicated to really reducing health disparities associated with hepatitis B, really by increasing awareness, screening, vaccination, and linkage to care for high-risk populations across the United States. We were founded in 2012, really with the mindset of convening people, stakeholders, experts, who are doing the work, the grassroots work on the ground, and bringing them together to a forum to really share ideas and best practices and really have a national voice for hepatitis B in the United States. We're co-chaired by APCHO, which is a large national organization of community health centers representing Asian Americans and Pacific Islander communities. And we're a coalition of coalitions. So like I mentioned, many of our partners that you can see by the green highlight and then the little flags here are where our partners are represented across the country. We have over 50 members, both national and local, located in 24 states and 30 cities across the United States. And we're expanding really monthly, which is really exciting to see. We have ongoing initiatives and capacity building programs that have been around since our founding, really with focus on Asian Americans and Pacific Islanders. You can see here from some of our outreach activities, we work directly with the CDC No Hepatitis B campaign to really help provide feedback and recommendations on needs for our communities on the ground. We work for coalition building and membership development. We have a peer mentoring program that really helps uplift new members just starting off and connects them with a more experienced coalition, for example. We have a mini grant program which works to support capacity building through screening, education, and outreach, and developing coalitions themselves across the country. We have an annual summit, much like the World Hepatitis Summit, but we convene on a national forum to really talk about best practices and bring together key leaders and opinions on different activities going on the ground. We also host regular webinars, which I invite you to check out at our website, hepbunited.org. We also, as I mentioned before, work with CDC on messaging and outreach materials. So we have a lot of new activities that we are working towards this year. We're expanding our coalition-focused outreach to move beyond Asian Americans and Pacific Islanders. We realize that there are many communities in the United States that need really targeted outreach and specific messaging for their cultural preferences. And so we're really thinking about reaching out within the African immigrant space and also among persons who use drugs, so within the harm reduction community as well. So these are new populations that we're really trying to target outreach. We also are working on a community health center learning collaborative with our APCHO partner. And really the goal of this program is to improve capacity of health centers or federally qualified health centers serving Asian Americans, Native Hawaiians, and Pacific Islanders, African immigrants, persons who use or inject drugs, really to implement hepatitis B focused education screening and linkage to care programs and promote cross-sector partnerships, really thinking about sustainability within our health systems here. We also are working on community coalition leadership development program to really enhance particularly those members that are just getting off the ground to improve their capacity of local coalition leaders to lead and grow community-based hepatitis B coalitions. So really to continue to expand our capacity and best practices in doing so. We also are working on a community health education program to bring in new key experts across the country to improve hepatitis knowledge and awareness, competency among community health partners using a community health worker training model based off of the Project ECHO model, which was started in New Mexico for hepatitis C treatment, but really thinking about that from a public health lens, using case-based learning and didactic training from experts in public health and hepatitis B specifically to really get the message at the grassroots level. We also have working groups that will guide our strategic direction for these new populations that we're bringing on, really centered on health equity as well. So we have a working group that's really focused on how we can really encompass that in everything that we do. We'll have a harm reduction working group that will really guide strategically how we address harm reduction in the United States, what is needed, where are the gaps, and how we can work towards addressing those. And then we also have a Native Hawaiian and Pacific Islander working group, which will work at doing the same thing, identifying gaps, cultural preferences, and needs within this space so we can really work on addressing those collectively as a coalition. We also have the Be the Change, which is a Hep B United grassroots and state advocacy program. So really thinking about advocacy at the local levels, city, state, and regional. There's regional advocacy trainings that are ongoing, really to bring advocacy training and lessons learned from advocacy that we've learned at the federal level to the grassroots level to train individuals on how to do it in their locality. We also have monthly state advocacy calls in which we allow people to come in, share updates, legislation, policy, and also get suggestions from our experts in DC on advocacy and best practices for that. And I just want to say thank you so much. And if you're interested in learning more about Hep B United or any of our programs, you're welcome to reach out, and my contact is there. Thank you.
That's fantastic, Catherine. Thank you so much for going on the hop like that. It looks like we now definitely have our videos connected. So we're going to move straight to a presentation from Rosemary Delabrie, the Coalition Plus France.
My name is Rosemary Delab, and I'm the Community-Based Research Manager at Coalition Plus. Coalition Plus is an international network of community-based organizations involved in the fight against HIV and viral hepatitis. I'm pleased to present to you today results from a Community Values and Preferences survey that was conducted in collaboration with the World Hepatitis Alliance and the World Health Organization. While great strides have been made in terms of quality and affordability of hepatitis C treatment, the service pathway remains complex for many individuals who are exposed and or living with hepatitis C. It is therefore important to identify the values and preferences of these populations in order to propose and or adapt services that meet their needs. It is within this context that I will be presenting results regarding a survey that was conducted, which aimed to identify and understand the values and preferences towards decentralization, task shifting, and integration of hepatitis C services among potential end users. A particular focus of this presentation will be on decentralization. This was an anonymous self-administered online survey that was available in English only. The survey was developed as a collaborative effort between the World Hepatitis Alliance, Coalition Plus, and the World Health Organization. The survey consisted of 42 multiple-choice questions, and the participants had the option to provide additional information in a free text box if they wished to do so. The survey targeted participants who were 18 years or older, were living with or affected by hepatitis C, and all participants needed to confirm their willingness to participate in the survey before providing any answers to the questions. The survey was promoted by Coalition Plus, the World Hepatitis Alliance, regional WHO offices, and the Treatment Action Group through social media, mailing lists, and direct contacts. And data was collected between the 8th and the 22nd of September of last year. Overall, 210 people from 49 countries participated in the survey. Median age of participants was 42 years old. The majority of participants were male, living in an urban or large city area, and had a high level of schooling. 72% had previously been tested for hepatitis C, among whom 40% had tested positive. Among the participants who provided information regarding hepatitis C treatment, 91% indicated they were currently or had been treated for hepatitis C. Regarding identification with key populations, participants identified with people living with hepatitis C, people who inject drugs, people who formerly inject drugs, as well as people living with HIV. When asked where the participants would prefer to be tested, the most popular choices were community-based organization center and place of their choice using a self-test. As we can see from this quote on the right, an important consideration for the testing site was somewhere where the participant would not experience discrimination. Participants also reported an interest in accessing confirmatory viral load tests outside of the hospital, with the greatest preferences for community-based organizations and primary healthcare clinics. A large majority reported that they would like to conduct initial and confirmatory tests on the same day, mainly to confirm their status and to start treatment quicker. Almost all, 93%, would like to conduct the initial and confirmatory tests at the same place, and the main reasons for this preference were convenience and for community-friendly site. Regarding preferences for treatment location, once again we see a strong preference for community-based organization center, as well as same site as testing site. As we can see from the quote on the right, having a community-friendly site is an important consideration for treatment location. Regarding when to start treatment, 85% of participants indicated they would like to start treatment on the same day if they had positive viral load. Main reasons for this preference were to avoid exposing family and friends to hepatitis C and to have continued follow-up from testing to treatment. Almost all, 92%, would like to be tested and treated in the same place, mainly for convenience and for continued follow-up from testing to treatment. As we can see from the quote on the right, participants stated, same site means clear continuity of care, avoiding having to repeat personal story issues and build trust with new clinicians or workers. To conclude, the results of this survey provide evidence that decentralized services would be particularly advantageous for both testing and treatment. The provision of services in locations where participants would feel comfortable and not experience discrimination was an important consideration regarding testing and treatment locations. Having testing and treatment services in the same place and providing them on the same day would potentially increase linkage to care. Overall, we can see a need to diversify testing and treatment solutions to respond to different needs of different populations and situations. We aim to pursue additional research to further explore the tendencies found in this study. I would like to end by thanking all the participants of the Values and Preferences Survey, as well as our collaborators, the World Hepatitis Alliance and the World Health Organization. Please feel free to contact us if you wish to have any more information.
To say thank you so much. It was great to hear the last presentation, particularly to have the research to back up the decentralizing. I think we're going to move on now to the next presentation, which is, I can't say your name. Your name.
Nalini Rajkumar.
And the presentation from India is the Community Network of Empowerment India, and it's a community-led hepatitis B and C care model, including same-day hepatitis C test and treat. So can we play the video, please?
First of all, my heartfelt gratitude to the organizer for allowing me to present our experience of this community-led same-day test and treat of hepatitis C in this summit. To give you a background of our organization, CON stands for Community Network for Empowerment, which is a state-level network of 11 community-based organizations of people who use drugs, and it was established in 2011. Since 2014, we were working on hepatitis C with a range of activity, from awareness building to providing free diagnosis and treatment, working with the government, developing treatment model, including in prison. We also develop policy material and providing uninterrupted HCV services during COVID-19 restriction. We have also been involved at the state and the national level advocacy activity to improve and enable quality HCV services. When we were working on all this, Government of India had also started implementing national program in 2019. Testing and treatment are available free under this national program. However, uptake of hepatitis C care is very poor, largely due to the lengthy pre-treatment process. So we developed this model of same-day hepatitis C screening, diagnosis, and treatment among people who inject drug as a replicable model. To give you further background, a little bit on the prevalence of the infection. We have around 65% hepatitis C prevalence among people who inject drug. Hepatitis B prevalence is around 10.8%, whereas co-infection of hepatitis C and B is approximately 4.8%. Going on to how we have done this in terms of the method that were involved. We work with the drug treatment center, targeting people who are undergoing drug treatment at the rehabilitation center. We provided on-site rapid diagnostic testing for HIV, hepatitis B, and hepatitis C. People who were negative are counseled on prevention of hepatitis B and C, including hepatitis B vaccination following WHO rapid regimen dose. The blood sample for those participants who were tested hepatitis C antibody positive are collected. They were transported to Babina Diagnostic, where ICV RNA tests are done using TrueNet MolBio. Blood sample for hepatitis B positive patients are transported to government hospital for DNA tests. People who were found to have RNA positive confirmed were initiated treatment on the same day with the advice from the doctor at the Jennings Hospital as per the guideline of the national program. We provide support to all the participants during this whole process. We will continue to provide until they are tested for SBR test, which we have just started in the past 1 week. This slide is just to give you more in details on the location of where the test was conducted. This is a map of Manipur in 70 days between November 21 and January 2022. We have conducted 23 camps at 22 locations as shown in the map. All the participants were male because the drug treatment center that we approached were all of male. Out of 643 individuals we approached, 540 of them are eligible as per the criteria that we set, of which 523 of them participate and screen for hepatitis C antibody, hepatitis B surface antigen, and HIV. During this time, what we observed was among 523 participants, 45.5% of them were hepatitis C antibody positive, 2.9% were positive to both hepatitis C and hepatitis B. 1.7% had only hepatitis B positive. 0.8% were HIV reactive. Another 0.8% were found positive to both hepatitis C and HIV. 0.4% were found positive to all the three viruses. 0.2% were positive to both hepatitis B and HIV. We have provided to all these 45.5% HCV treatment on the same day. To summarize the above in terms of to make it more clearer for everyone, and this data is updated till 7th of May, we screened 523 people, of which 49.5% were found to have hepatitis C antibody reactive. 100% undertook RNA tests on the same day, of which 64.5% were confirmed to be viremic. Out of these 167 people, 99.4% were initiated hepatitis C treatment on the same day. Till 7th of May, 13.3% are eligible for undergoing SBR tests. We have conducted SBR tests of 95.4% at the moment. We are now seeing SBR achieve rate of 90.47%. In terms of the time that were involved in the process, starting from rapid diagnostic test till the initiation of treatment, the number that we have is 164 because 2 people out of 166 tested Hep C positive were also co-infected with hepatitis B. The median time that was taken was around 6 hours 49 minutes with a minimum time recorded as 4 hours 36 minutes and maximum of 12 hours 18 minutes. Here, I would like to note that we can decrease this minimum and maximum time to at least another 50%. This time, the median time was longer because we were allotted and we used only one extractor. If we utilize 2 prep extractor of MolBio machine, the median time would have come down to at least another 50%. There was a limitation in the availability of infrastructure that made the median time little longer. To conclude, the success of this model was built on National Viral Hepatitis Control Program, which offer free HCV treatment, peer support that can provide help recipient of care navigate the care pathway. This community-led initiative where partnering with existing institutions can provide high quality, quick and comprehensive care. And we believe that that the equipment we use, that is the cartridge-based technology, if it is available everywhere, this model can easily replicable at other settings among people who inject drug. I would like to thank to all the volunteers of CON, all the drug treatment center and the community who volunteer, our colleagues from Babina Diagnostic, Jennings Hospital and National Viral Hepatitis Control Program. I would also like to thank Find and Treat Asia for their financial and technical support, without which developing of this model would not be possible. Thank you.
Thank you so much. Incredible presentation. We have got the other presentations lined up now, so we're going to move over to nurse-led hepatitis C testing and treatment in rural settings in Battenberg Province, Cambodia, which sounds fascinating. I've been there. It's an amazing place. But Daniel O'Keefe and Suna Balkan. So can you please play the video of presentation of Daniel O'Keefe?
Hi everyone, and thanks for coming. Today I'm describing the Nurse-Led Initiation Pilot Project, which was a nurse-led hepatitis C testing and treatment project in a rural setting in Battambang Province, Cambodia, and this was implemented by Médecins Sans Frontières. With the advent of DAA therapy for the treatment of chronic hepatitis C virus, this has made the global elimination of the disease a possible reality. However, only 12 countries are currently on track to reach WHO elimination targets, with the central reason for this being the ongoing inaccessibility of hep C testing and treatment in many countries, for many and complicated reasons. In response, simplified, decentralised hep C care is now recommended, with tasks shifting to less specialised staff, including treatment initiation and maintenance often performed by nursing staff. In 2018, MSF implemented a highly simplified hep C care project in the Cambodian Battambang province from 13 basic rural primary health care centres. Using primarily nursing staff, over 10,000 patients were screened using rapid testing assays. Treatment initiation was completed by a general practitioner based at the local referral hospital, and most treatment maintenance was performed by the health centre nursing staff. Patient retention and treatment effectiveness was high, with treatment effectiveness reported at over 96%. Following on from this project and expanding, in 2020, MSF implemented the Nurse-Led Initiation Pilot Project to evaluate pre-treatment assessment and DAA initiation and maintenance performed by nursing staff in 2 rural operational districts in Battambang, with 27 participating rural healthcare centres. The NLI project was implemented via a highly simplified model of care with minimal infrastructure, without on-site doctors, FibroScan machine, or full lab capacity. Here we describe the outcomes from the NLI pilot project, including linkage to care, patient retention, treatment effectiveness, and occurrence of adverse events. To describe the treatment model, patient screening was performed via active case finding in local villages and passive case finding in rural health centres. Hepatitis C testing was performed using rapid testing assays. To expedite DAA initiation for patients diagnosed as Hep C positive, prospective pre-treatment assessment was performed by nurses at the viral load testing appointment prior to blood being drawn. Nurses were trained to recognise signs of decompensated cirrhosis, patient comorbidities, or poor clinical condition. If these were identified in the patient was referred to the local referral hospital. For those where it was not identified, they were deemed eligible or appropriate for nurse-led treatment initiation. At treatment initiation, nursing staff provided information about treatment adherence and potential side effects. All patients received a regimen of sofosbuvir and decladisvir orally daily for 12 weeks, provided in 1-month prescriptions. At treatment months 1 and 2, patients were checked for adherence to treatment. If, during the course of the treatment, the patient experienced any side effects, they were immediately referred to the referral hospital. For the purposes of evaluation, patients were considered to have completed treatment if they collected their month 2 medication refill. We explored treatment effectiveness using SVR12 percentages, and these were calculated according to intention to treat analysis, which included all patients who initiated treatment as the denominator and all outcomes other than cure considered to be treatment failure. We also analysed treatment effectiveness according to a modified intention to treat analysis, which only included patients completing 12-week post-treatment viral load testing as a denominator. Differences in treatment effectiveness were compared by sex, age, and operational district. During the study period, which was between June to September 2020, over nearly 11,000 patients were screened, and of these, 920 were antibody positive. Again, of these, 547, or 61%, were viral load positive. Of those who were viral load positive, 3% were not initiated onto DAA treatment. A minority were assessed as requiring initiation at the referral hospital, being 38%, while most, being 329 patients, or 62%, were assessed by nursing staff as being appropriate for DAA treatment initiation and maintenance led by the nursing staff. The median turnaround time between viral load testing and initiation appointment was 8 days. All of the 329 patients initiating treatment via the NLI pilot project completed treatment. 14 patients did not return for post-treatment testing, 2 of these being due to death unrelated to the hepatitis C treatment, and 12 being lost to follow-up. According to intention to treat analysis, which included all initiating patients as a denominator, 310 patients, or 94%, were cured according to SVR12. Analysis by modified intention to treat analysis, which was restricted to the 315 patients completing post-treatment testing. Again, 310 patients, but 98% achieved SVR12, and 5 experienced treatment failure. Across patient subgroups and analysis methods, SVR12 percentages were consistently high, with between 89 and 100% achieving SVR12, depending on the subgroup and the analysis method. The NLI pilot project evaluated a real-world Hep C care model and demonstrated high levels of patient retention and treatment effectiveness and low adverse events. After 2 days of project training, with ongoing supervision, NLI staff were able to assess liver decompensation and patient comorbidities, to initiate non-complicated patients onto treatment after diagnosis and follow them up to very high levels of treatment completion and cure, with very minimal infrastructure. These outcomes speak to the competency of the NLI nursing staff, which despite the constraints of their context, and also to the safety and effectiveness of current DAA treatments, further confirming the potential of Hep C care as provided by less specialised staff in community-based settings. Such implementation represents highly person-centred care, particularly as nurses and midwives account for nearly 50% of the global health workforce, and nurse-led models of hepatitis C treatment, initiation and follow-up have enhanced global Hep C elimination efforts. The NLI pilot project provides an exemplar model of hepatitis C care for other resource-limited settings, particularly in similar rural primary healthcare facilities. Thanks so much for your time, and we look forward to taking your questions.
Again, a really inspiring, amazing piece of work. And I don't know about you guys, but I have a lot of questions, but we do have one more presentation left first. So the last presentation, and it's a videoed presentation, is from Community Leadership Mobilising Australia to Achieve its National Hepatitis C Treatment Target. And the presenters are Amanda Bode and Kerry Fowley, Hepatitis Australia.
Hello, my name is Amanda Bode and I'm speaking to you from the lands of the Ngunnawal people, also known as Canberra, Australia. I pay my respects to elders past and present and to all First Nations people participating in the World Hepatitis Summit. Hepatitis Australia is the national non-government organisation and charity that represents the interests of 350,000 people impacted by viral hepatitis and our members. We are so proud to be a supporter of this summit. Today, I will describe one way in which Australian community leadership has been central to obtaining political support and funding to ramp up joint efforts to achieve 2022 national hepatitis C treatment targets. These targets are necessary for Australia to achieve the ultimate goal of global 2030 elimination. To date, Australia's hepatitis C response has seen significant success in some subpopulations, particularly people who inject drugs. This has resulted in a halving of the prevalent population in the 5 years since the introduction of universal, unrestricted access to direct-acting antivirals. This is a testament to people who inject drugs, to peer-based organisations, to hepatitis community organisations, and others who are working in the sector. However, treatment rates had plateaued, and COVID-19 has created further setbacks. Progress was becoming increasingly difficult to achieve. Programmatic activity had often been happening in silos, and geographic and social inequities in hepatitis C-related outcomes had become apparent. It was clear that Australia's business as usual approach was not sufficient to reach the 2022 target. In November 2020, Hepatitis Australia, AVIL as the national peak representing peer-based drug user organisations and people who use drugs, and other partners held a bipartisan event at Parliament House calling for more action on hepatitis C. At this event, the National Minister for Health committed to finding 50,000 people living with hepatitis C by the end of 2022 and asked for a proposal on how this could be achieved. This would, in effect, mean that Australia reaches its 2022 treatment target. Hepatitis Australia led a national collaborative policy process to develop the proposal and seek input and support from key stakeholders, including affected communities, national peaks, the clinical workforce, research institutions, and Australian governments. This process included the following steps: undertaking a policy, evidence, and data analysis, establishing a partnership with the Australian Department of Health, identifying activities that were effectively being implemented nationally, but not yet at sufficient scale. A key principle was finding activities that could work in tandem across community engagement, testing and linkage to treatment, and awareness raising. Drafting a proposal and obtaining input from the Department of Health and key partners, including other national peak bodies and research organisations. And then engaging with the Bloodborne Virus and STI Standing Committee, which is the national body that has stewardship of our national hepatitis strategies. This included seeking their input on the proposal. Following revision, we then recirculated the proposal to the Standing Committee for final support, before finally sending to the Australian Minister for Health as a collectively designed and committee-supported proposal for consideration. The response from the Minister for Health was positive and commended the efforts to co-design the proposal. In particular, the Minister observed that the proposal was an example of the partnership effort required to identify and support people living with hepatitis C. The Minister confirmed he had approached his health department to provide advice on the best way to take the proposal forward with support from Hepatitis Australia. Community leadership was central throughout this process, as Hepatitis Australia, as the national peak, had a deep understanding of community issues. We also had leadership capacity and broad networks to bring stakeholders together and mobilise around the shared initiative. All of this is consistent with the principles of the National Hepatitis C strategy, particularly partnership, meaningful involvement of priority populations, shared responsibility, and access and equity. The proposal put forward a collaborative approach that sought to scale up 5 pillars of activity concurrently in areas where concerted effort is needed and feasible. This includes national hepatitis C awareness campaigns with involvement from affected communities, a national point of care testing program, enhancement to primary care case finding, a national hepatitis info line, and a systems level working group to undertake national project coordination and evaluation. Each of the pillars are interrelated and mutually reinforcing. By implementing all activities concurrently, there is scope to amplify their reach, to reinforce messages, and to increase engagements and outcomes. The Australian Department of Health has allocated new resources to 5 partnering organisations to collaboratively implement each pillar. These partners are organisations with existing expertise, relationships with affected communities, and commitments to viral hepatitis elimination. The proposal is now an initiative called the National Finding 50,000 Project, and it commenced late in 2021. It involves an increase in funding and activity into Australia's national hepatitis C response and more than 250 potential partners in every state and territory. While project implementation is in its early days, the process to develop, advocate for, and ultimately obtain resourcing for the initiative shows increasing recognition that community leadership is central to the success of Australia's national hepatitis C response. We hope that this case study demonstrates a globally relevant example of how community leadership is critical in making hepatitis C treatment available to all and ensuring that we leave no one behind. We look forward to meeting with you at the next World Hepatitis Summit to report on progress and outcomes of the Finding 50,000 initiative. Thank you.
Thank you so much. We look forward to that, and hopefully in the next summit we'll all be in person and we won't have to deal with any of these horrendous IT issues. I wanted to say we've actually reached the end of the session. There's been no opportunity for questions. I wanted to firstly say thank you so much for putting together the work that's been involved in you all making the videos, doing the presentations, pulling it together. It's really appreciated. So thank you. There's lots of questions that have come up, and I don't know if you're on the portal, if you get a chance to answer the questions, Huma, there's some questions for you. And I think that if there's an opportunity for you to answer them, we'd really appreciate it. I know it's the middle of the night for some of you. You must be as wired as we are with electronics going wrong here. I wanted to say thank you so much. And what I hope is the next time, I really found it fascinating. I would have really liked an opportunity to have some questions. But apparently I have a message here, which is about, if you can stay on, please stay on and join us for the symposium on the impact of stigma and discrimination affecting people living with hepatitis B. I don't think any of you are here in Geneva because there's a message of a room you can go to, which would be better because there would be no electronics. I think I'm done for the day on electronics. I just want to say thank you. Is there anything you want to say? It's just been really hard work, and I know you put so much work into it. So amazing initiatives, programs, presentations. Thank you so much, everybody. Really appreciate it. And if you do have an opportunity to answer questions, please do. Thank you.
Thank you.
Thank you.
Thank you.